Hello again. Vlog number 2. Great. So I'll kind of skip the introduction since you probably know who I am. But this week's topic was the social determinants of health and kind of the different aspects of it, from environmental to behavioral to political to social. You got the whole range of them, and they're really all interconnected. If you really think about it, that's something that I've been thinking about a lot. Just kind of get into it. This vlog had a lot of interesting things to talk about in terms of just what was provided on Blackboard for us to view. One of the things I kind of wanted to focus on in terms of the social determinants about this research on these social determinants, because I think we've explained pretty well what these social determinants are and have explained that in the talks we've had. But I think their application to research is something that's really interesting, at least to me, being that I would like to do research in the future. But what's it called? Two of the things that I found really interesting was the one of the videos was called the Houston Cancer Cluster, and they were talking about how there were higher rates of cancer in this environment because of the surrounding pollution. But the thing is, at this point, they're not doing much about it because there's no research to prove that it's there. But it's like a lot of other things. These are lived experiences for these minorities and people of color. And it's a real shame that for the politicians to do anything, for any change to happen, you need to have data surrounding it. The thing is, data takes time, and there needs to be people to gather that data and do that research, and there's just not those people at this point in time. And I think it really it also is derived from an issue that there's a lack of representation, right? This is going to more into the political side of things, but the people who are policymakers as well as the researchers, they're often not from these communities. They're not often people of color. I think the percentage of them are very low. I'm not sure what the exact one for scientists are, but I know in terms of physicians, I think it's like it's approximately 5% for both African Americans and Hispanics. But and assuming it's something similar in terms of like academia and PhD and principal investigators, that's problematic because there aren't people to kind of serve as that kind of intermediate advocate for these people, right? And it's a real shame because people don't acknowledge it as a problem. They're like, oh yeah, it would probably be good if we had more black doctors and scientists. But they don't think about the underlying interconnectedness and how this is a social determinant of health. The people who are making these decisions, because unfortunately, because of all the other determinants that they have to prioritize, like the financial aspect. Think about it. If someone is struggling, they got to work all the time, and they don't have time to take off to bring their kid to the hospital, or they don't have time to take off. What's it called? To go do whatever they need, basically, and then they're working all the time and they can still barely afford food. They have to get what they can get. And again, this leads to decreases in health outcomes, and it just compiles and compounds into more problems, right? And then I also wanted to kind of connect the talk, or the interview rather, with Harriet Washington about how the benefits of research have often been at the cost of people of color. Not like, of course, the Tuskegee trials are something that's well known, and on syphilis, but there are so many others that they were talking about. What's it called? A lot of OB-GYN and surgical research was done on patients of color, and they were just basically guinea pigs. Like seriously, it's awful. And just they were talking about the availability of research in two ways, and one, that it's not out there. We kind of talked about that with the previous video, that there isn't this research. There's enough research to make people move, to make people change. We gotta get that research out there, right, and make it known, and then also make that research available. That's something that she was talking about, how she worked or she went to school at Harvard, and yeah, if you go to study at Harvard, you're gonna have all the Harvard resources. That's amazing, but everyone ain't got those, right? Your average person is going to have access to this research. Your policymakers aren't even maybe gonna have access to this research because a lot of it is behind a paywall nowadays, and I think that's so unfortunate that a lot of the time research is made and it sits there in a journal that maybe like some academics would look at and be like, interesting. Maybe I'll do a study related to this, but it doesn't affect change, right? And that's the whole point why we do research. I think a lot of us, especially in public health research and biomedical research, want to help patients, and it doesn't do that if it's just in a journal. So I think that also needs to be a problem that's solved. And I think that a lot of people notice that problem, but they don't think of it as a racial problem. Everything is interconnected. That's what we're seeing, right? And that it really it does affect the health of patients. And by fixing this, I think it'll allow for a lot of improvements. And then kind of moving on to something else I want to talk about was the implicit bias test. Surprisingly, I took the one on race. I probably should take the one on gender. I'm honestly kind of curious, so I'm probably gonna do that. But the one on race, actually, it said I didn't really have any bias, which was surprising. I don't know. I felt like I would have something. I didn't know if it was towards black people, towards white people, where it would be, but I felt like I would have some bias, especially when I took it. The second one, where I think they flipped the labels and the bad or good. It took me a significantly slower time, so I'm not sure if it was the fact that it was flipped or the fact that maybe I had some bias and it just wasn't detected. Who knows? But I think it would be interesting to see some more research on that and kind of either read up on it if it's available, or maybe even do a study in it. It's like in the healthcare setting specifically. I think it would be very interesting. But like the implicit bias of an individual will significantly impact here. That's another determinant of health. It kind of in that social category. And then the two articles that really jumped out to me. There was one article by Ren et al. which looked I believe at the effect of physician care and kind of what their perceptions are of patients of color. And I just found it not it was expected. Right? That's the thing. It's unfortunate, but it was expected. So it's not like, wow. It's like, yeah, that's a problem. We need to fix it. And that they typically saw people of color as having lower intelligence and lower socioeconomic status, and just assuming these things about a patient. And they may be there, they may not be. You gotta ask. You gotta make sure about this specific patient, right? You gotta look at them as an individual and not just be like, that's a black person. They're just here for drugs, or they're just complaining about their leg pain. Their leg pain all here. You gotta consider these things, and it affects treatments. Again, looking at rates of pain medication assessment. That's because they have different perceptions of black people, and that's one of the main underlying factors. And again, it's all connected, right? I've been saying that a bunch, but it's true. And then the other study by Johnson et al. Looked at the communication in between. I think communication is critical, not just in the healthcare setting, but I think if people are truly able to communicate in an effective manner and really get that information across and have that bi-directional conversation, right? Not just one person spitting out information, which can happen a lot in the healthcare setting. It'll solve a lot of problems, and it will better society as a whole if we're better at listening and communicating, right? And I just found it really, that one was more interesting, that there was a greater level of physician kind of dominance in the conversation, and what's it called, just decreased patient-centered communication. I think that's awful. I think that's absolutely awful. And then to kind of get to the actual questions, I kind of talked about a lot what I found interesting and surprising. But what can I do with this information? Now, again, it's hard for me to do my own studies because just I haven't had that level of formal education yet, so I still need to work under someone and learn more. But one day. But now it's really more kind of on the practice side of things. And I think learning about these kind of various different origins of these disparities and these determinants and where they come from, it allows you to better evaluate a patient, because a lot of the times patients are less likely to talk to you. Of course, like from the two studies I was mentioning, why would they? Why? Of course, they're not gonna trust you because you're not gonna listen. Healthcare has failed these individuals, and we need to work to recuperate that. And I think asking them questions and just seeing, like, okay, yeah, you can ask them, oh, where does your leg hurt? Oh, your leg hurts. What do you rate it? Why does your leg hurt? How did you hurt it? Oh, okay. You were on your way back and you fell off your bike. Okay, why were you biking? To exercise? No, you had to bike 5 miles to get to work and then home. Oh, okay. And then we get to kind of those determinants. Why are you biking? Because you can't afford a car. You're undocumented citizen, right? And we can trace them back. And we really, in order to solve these problems, we need to get to the root of them. Fix it at the root. Because if we keep chopping off or just put a band-aid on, it's going to come back. It always will. It always has, right? That's not a solution. We can't just rely on these temporary fixes. And just thinking about this, and even if a patient doesn't say it, you want to kind of have these as something kind of in your back of your mind that you can consider when deciding on what your treatment plan is and how to best help this patient. Because yeah, you can give them medication, but if they go home and they're not going to take it, what good does it do? They're going to be back in the emergency department tomorrow or in a week or whatever that happens to be. And then this is why, this is truly why I think that racial and ethnic minorities have worse health, because of these social determinants combined with these biases seen in healthcare. And it's really awful, right? And then just like what I want to do now is really just kind of change the way I approach practice and the way I kind of talk to and help patients, right? And take the time, because like, yeah, you don't have a lot of time in an ambulance or in the emergency department, but really giving those extra few minutes can be critical. And then what I want to do in 5 years, again, I said it's kind of harder for me to do research. Well, I still do research under a few different people, and I have my own little projects like systematic reviews and some data analysis kind of thing. But I really want to do some bigger studies to evaluate what these social determinants are and these kind of networks of how they kind of interact with each other. For my health systems services class, I'm going to write a paper, kind of in the process of writing it, and it's on the racial and ethnic health disparities in pre-hospital cardiac arrest management, and we have to create a kind of a conceptual framework of how these kind of things do after researching these kind of various factors and factor groups. I have it here on my computer, and it's really they all affect each other. Like the community factors will affect the cardiac arrest outcomes because they affect the arrest characteristics. If people in your environment don't have that level of education in terms of knowing to do CPR, knowing to call 911, and being able to recognize cardiac arrest, you're not going to get bystander CPR. And that's why we see lower rates of bystander CPR in Black and Hispanic communities. And then because you don't get that bystander CPR, your rate of survival from that cardiac arrest drops significantly. And then that's not even to consider other aspects like the provider influence. We kind of talked about in the papers that it's often left to the physician to decide how long they're going to run your code for. If you're a little child, they'll probably run it for an hour and a half. Sometimes I've seen, but honestly, it's unfortunate. I remember there was one patient who was an older Black male, and they did what's called a slow code, where they'll run the code, but at one point, the physician, or I think it was the nurse, who told me, yeah, he's not coming back. You see the pupils, they're gone. They're just doing this for the family. And I think it's so unfortunate. At the time, I really didn't think about these, what's it called? Not social determinants, but yeah, in part social determinants that affect these provider influences. And then also all the other determinants. Again, this patient, he came in because he didn't have dialysis. And a lot of the people thought, oh, he just didn't get the dialysis because he was lazy, and then that's why his electrolytes were all causing the arrhythmias. But maybe there were a bunch of other reasons. Maybe he couldn't get to the dialysis clinic. Maybe he couldn't afford the dialysis clinic because he has no insurance. Maybe he had to watch his kids or something like that. Maybe he had to go to work and couldn't get it. And maybe that's why he died. These are all fixable problems. I've already been talking too long, but really I want to integrate that into research and fully explore it, because there is a lack of research, and I think even myself as one person can make at least a little bit of change and bring those to policymakers to create change on a systemic level. Thank you.